confrontational test. The confrontational test, do we know how to do that? Do we go over? So confrontational test is you as an examiner cover one eye, that patient covers the same eye, and then you're coming in and you're testing their peripheral vision from the different fields, and then you switch eyes again, same thing, you're testing their vision from the other fields. That's our confrontational test. If they have unilateral blindness, that's a score of 1, and if they had blind, or if they are blind for whatever reason, they came in blind, they have a history of blindness, there's trauma to their eye, whatever it may be, they will receive a score of 3. And I see Abdul writing stuff down. On the handouts that I gave you, I didn't print out this PowerPoint slide, but on the handouts up here, the NIH stroke scale, it's going to list them down into boxes for us. We're also looking for facial palsy. Is the face normal? Is it symmetrical? That's one of the first things that we look at on our stroke patients. Do they have minor paralysis? How are we going to check for paralysis? Smile. That's the easiest one for us to do. Smile, puff out your cheeks, lift your eyes, absolutely. We're looking, they may have a slight asymmetrical smile, or it may be total. I mean, it might be the whole way down that you can't smile at all. Yes.
I have a problem with the Bast palsy. They are the same. The Bast palsy patient and the stroke patient look the same. How do you differentiate with that?
Because we would determine a palsy patient would have a negative CT scan. They wouldn't have any other symptoms besides that palsy, that facial droop. To be honest with you, a lot of times we do activate a stroke alert and do the CT and the head CT and follow up on a stroke patient just in case. But we can look for viral infections. We can look, you know what I mean? That's usually just one isolated symptom on a palsy patient. That's a very good point because they are going to have that facial droop. They're going to have that numbness. They may have that vision loss in their eyes, but their extremities should be fine. You know what I mean? They should still be cognitively with it. They should still have that orientation. They should still have everything else except that facial movement. We can even see complete paralysis, where it's completely flaccid, it's not moving at all, it doesn't do anything on our patients. We talked about how to do it. We can have them smile, raise your eyes, show your teeth, that kind of stuff. Arms, we're looking at our motor arm movement. We're looking if there's drift. When we do drift, how do we do drift in our patient's arms? Yeah, you guys got it. So if we have the patient, we want to do palms down too, which you guys all showed me. So palms down, holding them up, and we're looking to see if they drift. And you want to count for a full 10 seconds. That drifts with a score of 1. They do drift a little bit within that 10 seconds, but it doesn't slam back down to the bed. So they can do it, but it starts to come down. That's some effort against gravity, is they can give it up, but it's almost coming right back down. Some people say within 5 seconds as arms come back down, so they can get it up, but they can't hold it up. No effort against gravity is when you lift that patient's arm up and it's just slamming right back down to the bed again. No movement, obviously, is no movement. Each limb is tested in turn, and that's one thing that we have to remember too. A lot of us want to do both arms at the same time and then we're watching. It's actually recommended that we do one arm at a time, and we actually start with a non-affected arm first. If there is an amputation, again, because we know that it happens, the patient is not penalized for having an amputation, you would just write UN and see on the score how you can have left or right. Whatever arm is amputated, you would just include a UN because you don't want to give them more points because the higher the points are, the more severe their stroke is, and that's something that they can't control. Again, same thing with legs. We're looking at the legs for drift as well. Legs, we only make them hold it for 5 seconds, not 10. Same thing. We're just going to have them lift their legs right off the bed and hold it. We're seeing how long they could do it for. Again, each limb is tested, each leg is tested independently, starting with a non-affected limb first. We're looking for ataxia. Do they have it? We always grade this and we look for ataxia, but sometimes I feel like people don't even know what ataxia is. Ataxia is the impairment of the ability to perform smooth coordinations with voluntary movements. That's what we're looking for. So that can they bend, can they move, or are they having this jerky, rigid, almost that cogwheel effect? That's ataxia. So as we're looking for this and looking for their arms, we're looking to see, are they jerky, are they movement, are they fluid and smooth like yours and I's are? Again, we can pair one limb with 2 limbs. It may be an upper arm or a lower leg. It doesn't have to be both arms or both legs. It can be one right arm and your left leg. That would be present in 2 limbs. Does that make sense? Okay. This item is aimed at finding evidence of unilateral cerebral lesions. we want to test limb ataxia with the patient's eyes open and then again doing range of motion with them. Another thing that we can do to test limb ataxia is some people do that finger to nose. You hold out your finger, the patient comes back and forth, back and forth. That's one way that we can test ataxia. Another way for us to do it is have them do the heel to shin test. And you have to remember when we do the heel to shin test, it's not just down once, it's up and down a couple of times to make sure that they can do it. And again, you want to do limb ataxia on both legs for that. Again, if they have an amputation, you don't want to penalize them for it. They can't help it, so they couldn't do the finger to nose, or both legs. If they have the one leg or the one arm, they get full credit for it. Ataxia, you do test ataxia even in the patient who is aphasic. You do not try to test ataxia if the patient is paralyzed. They can't do it, they will receive a score of 2. Sensory. We're testing sensory in our patients. We're looking for if they have any sensory loss, mild to moderate sensory loss. The patient can feel the pinprick, but they think it's less sharp, less dull, more dull on the affected side than the other side. We do this, again, when the patient first comes in. We're going to be touching their cheek. We're going to be touching their foreheads. You want to use multiple parts of their bodies. You want to go down their arms, down their legs, right? A lot of people just use their face, but no, we have to test sensation everywhere on that patient's body, so you need to go down. How many of us carry, the safety pins around with us? Not very many. Another trick that we can use when we're in the hospital is those Q-tips that a lot of units have. I know we definitely stock them here in the ED. You can use the top part of your Q-tip for the soft and then that harder part for the sharp. But before you get started, you want to explain to the patient, hey, this is the soft, this is what it feels like. Can you feel this? Yes. Okay, this is the sharp, and let me touch it to your skin. This is going to be what sharp feels like. Do you understand the difference? Because you need to make sure that they can differentiate before you even get started, or it's not going to be a valid test. Next, we need to test their language, and I'm going to scoot to this picture next. These NIH pictures are found throughout the hospital. They're stocked in our NIH stroke awareness books, stroke education books, and they're also going to be posted on each and every single unit.